how do you scale personalized medicine? It will happen over time as more evidence is built in delivering this care. How can you replete your energy state? And how can you remove things and understand what depletes your energy? One of the things that we're seeing is this therapeutic plasma exchange. Exosome therapy, which is derivatives of stem cells, is going to be more prevalent. What they do is they signal your own body to have a massive healing response. I think the role of peptides, I think that's really going to be growing a lot more. We personalize strategies for patients here based off data, where we curate a personal blueprint of interventions, and we put a care team around our patients to improve their outcomes wherever they're at on their journey of health.
Simon, who's recently had his 70th birthday, and his biological age is 38.
My energy levels are a joke, they're through the roof. I get numbers back. Apparently I'm 38 years old. Great, that sounds good. I have a VO2 max of a 36-year-old. What ends up happening is two things, I think. One, you become mindful, and then you become addicted to feeling well. This is exactly what Dr. E is saying. It's personalised, and I like that.
Hi everyone, thank you so much for joining us to what we hope will be a really fascinating discussion. So tonight we're going to be exploring cutting edge developments in longevity science, and that will be making the headlines soon. From peptide therapies to the new GLP-1s to futuristic diagnostics which could predict early cancers and chronic disease prevention. So you'll hear firsthand from a patient who has had extraordinary results, and he's been undergoing some of these groundbreaking treatments, and he's got empirical data which shows how well he's been doing, and you'll be incredibly excited to hear that later. And generally understanding how these treatments transform lives now, but hopefully even have the potential to transform healthcare. And then we're going to finish off with some uniquely personal lifestyle strategies that we can all employ that are not the kind of thing you hear all the time, but that can be considered a sort of blueprint for our own longevity. So the star of tonight is Dr. Mohammed Enyat, who is a medical doctor in the UK, then did some more research in stem cell laboratories in California, and then set up HUM2N, the longevity clinic here. But fascinatingly, he is also a GP in East London. So he's got a foot in both camps. He's seeing what's coming around the corner, and he's seeing what the general population are having to deal with. And I find that so interesting, because I think a lot of people in the longevity sphere don't entirely understand what most people have to deal with. So I find that incredibly interesting. I'm Jessica Salter. I'm a lifestyle journalist with a big interest in wellness, but I've also been a patient of Dr. E's, and I came to him with chronic insomnia. I was kind of not even sleeping 3 hours a night, and he did a full blood test and fixed me, and so I'm entirely grateful to him. And he's been invaluable to me as a journalistic source, and I encourage anyone who's writes about longevity to add him to your contacts list, because he's really brilliant, and he gives you quotes with studies attached, which is so helpful. So I look around the room and I know quite a few of you already, and I know that you're experts in the field. And so we're going to hopefully dive straight in and have quite a high level discussion. But if there are any points of clarification you want Dr. E to make along the way, just raise your hand, but also save up any big questions for the end, because we are going to come to you. So we've got a lot to cover, Dr. E, but can you start us off by way of introduction, telling us how you got into this longevity space when it really wasn't such a buzzword quite a few years ago?
Yeah, I mean, I suppose the word longevity in medicine didn't exist. My interest in it was just really about doing good medicine. It's always been about how to give the best level care to patients, and beyond care, what does that actually mean to the patient when they go home and they live with their health state? How can they make their health better wherever they're at on their journey of health, in complicated health states, in disease, or in a state to optimize their health in high performance, physical athletes, etc., etc. And to me, that I felt that there was always something missing from what we learned in the core science at medical school in year 1 and 2, and then what we went on to go and deliver in practice, whether in primary care in the community or secondary care in the hospitals. Yeah, I just was kept on being curious, and my curiosity led me to Germany and Austria, where I learned at that time it was very much wellness medicine, diet and detox based. Worked in a stem cell facility in San Diego 2007 during my studies, and that opened me up to what is now one of the key hallmarks of aging, which is regenerative medicine. stem cell medicine? How do we slow that down, slow down the slowing down of stem cell production and replacing the healthy stem cells? That opened my eyes into the hallmarks of aging. And around that time, David Sinclair, Aubrey de Grey, and other scientists were coming out with all these findings of things that would slow down in the human body, which was then coined these hallmarks of aging, which turned into longevity science, of which they started to establish things that you could do to improve the likelihood of living longer, to make those processes work better. And so what I practice now is that longevity science as medicine.
Mm.
And we personalize strategies for patients here based off data, where we curate a personal blueprint of interventions, and we put a care team around our patients to improve their outcomes wherever they're at on their journey of health, for the short term, medium term, and the long term. Yeah.
I mean, you mentioned some of those big names in longevity science, and then we're also seeing kind of extreme biohackers like Brian Johnson. What are some of the craziest longevity measures that you see in practice, but maybe coming around the corner, and do they have any merit?
One of the things that we're seeing is this therapeutic plasma exchange. I think it's quite interesting because
What does that even mean?
it's essentially where you're filtering the blood plasma.
Yeah.
And they've been using that in intensive care for a long time.
Yeah.
They use that in dialysis. We filter the blood to remove some of the toxic proteins that we cannot clear out normally. Now, do I think that's relevant for everyone to do? I don't think so. I'm not convinced yet, but it's definitely around the corner.
Mm.
And that's part of the problem, is like, how do we work out what needs to be part of everyone's strategy for longevity and what is then reserved for certain people's at certain times of health or sickness. So I think that therapeutic plasma exchange is really interesting. Exosome therapy,
Yeah.
which is derivatives of stem cells, is going to be more prevalent in, it's been knocking on the door in kind of Western medical systems for some time, but it hasn't quite made it through. It's definitely available in certain countries, but there is some concern around many of these therapies from a longitudinal perspective. Like, from a long-term perspective, do we know there are maybe some concerns about what's going to happen? What does it do to the human body over a longer period of time?
Mm.
So exosome therapies mitigates against some of the longer term risks that stem cells have, because it's not a full living cell. It's just a protein of a stem cell, and it doesn't contain any DNA, and therefore, other people's DNA it doesn't contain. So it's regarded a lot safer, and it cannot cause other tissue to grow within the body. So that's one of the concerns around stem cell medicine. Whereas exosomes, what they do is they signal your own body to have a massive healing response. A bit like PRP does. You may have heard of platelet-rich plasma, which has been around for some time. But exosome therapy has been shown to be 10 to 100 times more powerful than PRP. So the regenerative medicine field, I think exosomes is really interesting. Another really interesting one I can keep them about.
Do one more.
One more. I think the role of peptides. I think that's really going to be growing a lot more. The most famous peptide you mentioned earlier is the family of peptides called the GLPs, the GLP-1s. We've all heard of Ozempic, Mounjaro. We're kind of fed up of the headlines associated with it. So that represents an entree into a new class of medications that's going to be hitting the high street or hitting the clinics over time, which are peptides. Why do I think peptides are here to stay? Is because they seem to be really safe generally, and that's why you're seeing so many people using the GLP-1s and generally quite safe. Yes, in the wrong hands at the wrong time, you're going to have side effects. I'm not saying that any of these treatments are completely safe for everyone. The role of a doctor is to prescribe to the patient in front of you the right intervention at the right time. And everything I'm talking about has an indication, a contraindication, a time to use it.
Yeah.
And that's why you work with specialist doctors. There's ones that are for weight loss, and that's all blood sugar sensitivity, and that transpire into weight loss. But there's peptides for brain health, short term and the long run. There's peptides that upregulate your own stem cell production. There's peptides that work for chronic fatigue and conditions that typically haven't had a great response. There's peptides that also can improve cancer therapies, allopathic cancer therapies, the traditional cancer therapies that you're having. There's peptides that you can use alongside that will improve the outcome of the cancer therapies that you're having. And so I was certified in peptides. I studied it in America. Peptides have been being used on patients amongst a cohort of longevity physicians like myself, in practices like myself, like what we have here around the world, but predominantly coming out of America is where I think they've been the most progressive and most supported by the marketplace, by the science, by the translation of science. And so we're lucky in the UK that we're leaning on the clinical experience on patients that America has provided us and the network of physicians and experts delivering that on patients. So there's a group of peptides that we're delivering to our patients that we feel has a strong body of evidence, but are also very safe and very effective. Things like TA1, TB500. I could list
They have
10
crazy names, don't they? Yeah.
currently until the marketing companies come up with something
Yeah.
cool. Going back to the GLP-1s, they started off with a single acting, so one pathway acting Ozempic. They went to the two acting tirzepatide or Mounjaro. There's a three acting peptide, so works on three pathways called retatrutide, which is a peptide as well. Obviously, all peptides that is showing even superior results for weight loss than the Mounjaro. And Eli Lilly, the pharmacy, is now scaling that out. But interestingly, peptides have been made by compounding pharmacies in the US for quite a bit of time before the big pharmaceuticals, which is very different to a drug. Drugs are made the other way around. They come from big studies because they're synthetic and they're not naturally occurring molecules, whereas peptides are naturally occurring molecules that we are utilizing. And that's the power of this type of approach and this philosophy when it's delivered well, is longevity medicine, is really upregulating and supporting your own biological processes and pathways to work better.
Yeah.
Right. And understanding what is happening naturally as we get older, but what is happening from accumulated environmental damage when your biological processes. Sorry, that's a bit of a tongue twister. But as the human body operates in the environment that we're in, right, it accumulates damage and that affects some of our biological processes. Now, of course, we have some personalized predispositions to those as well, where some of us will be more sensitive to UV light, as an example, and we'll get more sun damage. Or some of us genetically are more likely to deposit a bad type of cholesterol, which carries an increased risk for developing Alzheimer's. Or some of us have an increased cancer risk, etc. There are some fine tuning that we get down from our genetics that get up or down regulated from the way we live. Nutrition, stress, sleep, movement. It's not that complicated. and then around that, community, purpose, mission, values, right?
Yeah.
And so we will be talking about some of that, those
Yeah.
things that you can do yourself.
Yeah.
It very much is about how do I modify my environment to work for me, not against me. And then you go into the data. How do I understand my personalized risk in the longer run, but then also the accumulation of damage to where I am right now? Then when you work with practices like us, we start to work from the data backwards to get your systems working better.
Yeah. I think, I mean, there's such a media buzz around Ozempic and the GLP-1s. Do you see, you mentioned that third drug. Do you
Yeah.
see them as just becoming part of our lives now, that they're going to become more refined and that more and more people are going to be on them? I'm interested in the idea of whether people will microdose, whether they'll come up with different formulations for people who want to, who are not obese but want to get to a healthier weight. What's your thoughts on that?
My concern with it is that what we're not doing is supporting patients with an understanding of things that they can do themselves. And we're just applying the same disempowering medicine to patients in another form. As doctors, the traditional medical system is not empowering for patients. And the system isn't designed to handhold you with the solutions in your environment, in your reach, that you can do yourself by making the right micro decisions on a day-to-day basis, that you can teach your children, that you can teach your loved ones to make people healthier collectively. What it's currently teaching you is a quick fix. And that's my concern with it. And the problem with the quick fix is that you lose power, right? Because you don't know the things that you can do yourself to take back that power. And what ends up happening is that we just have, over longer periods of time, more and more sick people in society and doctors that are just giving prescriptions, not empowering our
Yeah.
patients. So I think you know what it's like. The market decides ultimately, right? And weight loss has always been the thing that the market wants the most.
Yeah.
There is a proxy relationship between, and I think, I think, does the marketplace need weight loss? If we look at the stats, it does, right? Because obesity is on the rise, type 2 diabetes is, at an all-time high.
Mm. What are your views on microdosing?
I think for the right person at the
Mm.
right time is I do it, I offer it
Yeah.
for patients.
Yeah.
So yes, it's a tool that we offer. And I'll give you some context of the number of times in our practice. So our practice is made up of, there's 28 in our clinical practice. We have a team of functional medicine GPs. We have a cardiologist, rheumatologist, 2 cancer doctors, 6 functional nutritionists. That's how we deliver our medicine. Each patient gets a doctor and a nutritionist. We run internal MDT meetings, and we take people through a program of care running 12 months. So we deliver it very responsibly. Of the thousands of patients that we've seen, we've probably prescribed, since during the time that GLP-1s have been out, we've prescribed less than 20,
Hmm.
25 patients out of more than 2,000. So when you have more tools, you rely on the medication less.
Yeah.
Supplementation, nutrition, lifestyle, the therapies that we have, which change the way you draw on fat, cryotherapy, cold exposure. So you can utilize the breadth of tools more. We know what's possible. And, there's nothing more special about us as doctors than anywhere else. It's just that we're spending time to learn about these things, and we have an environment where we can apply this personalized medicine. Does that answer your question?
It does. Yeah. In some cases, good, but you've got more tools at your disposal.
That's right.
Yeah.
And
And it's about digging out that research and applying those to your patients.
and you won't know what those tools can do for you unless you try them.
Yeah.
Unless you try ice bathing, cold showering, the breath work, keto for a little while, plant-based for a little while, sleep strategies, etc. Unless you try them and build state awareness, you're not going to know how you respond to those strategies. But those are all within our patients' grasp to do themselves at home.
Yeah. Now, while we're talking about longevity, the thing we're trying to prevent is dying too early. And one of those causes is heart health. It's huge, isn't it?
Yes, absolutely.
And there's some quite exciting treatments coming out for heart health, right?
Yeah, treatments and diagnostics.
Mm.
Okay, so first is really understanding that the way we deliver medicine for managing cardiovascular risk in the community, in primary care, in medicine in the UK is not personalized. There's big statistics about this. A 40-year-old comes into general practice, their cholesterol is up. That's predominantly the main marker we're looking at, LDL cholesterol, right? Who's had their LDL cholesterol measured? Yeah. Whose LDL cholesterol has been high? Okay. Just one. Everyone else, no one else here has one in the back as well. Okay. So, and then if your LDL cholesterol is high, you might have a window to try and modify, but usually they'll say, okay, look, we've got to start talking about a statin, which is the first line medication for it. But there are several risk factors for developing cardiovascular disease. So the progression of taking cholesterol, calcifying around that cholesterol, then the endovascular lining, so the lining of the blood vessel becoming likely to rupture, which then, or inflamed, which then causes the cholesterol to spread out and cause clots. That's a process that requires 4 main things. A bad type of cholesterol, and we'll come to that, back to that in a second, because not all cholesterol is bad. The second is blood sugar response, and high fasting insulin or high circulating insulin is pro-inflammatory, right? So we check blood sugar, but we don't check fasting insulin. In general practice nutritional medicine, we ignore that. But actually, we now know that insulin circulating is a big part of the problem. It causes endovascular irritation. Third marker is generalized inflammation within the body, and we have a crude marker like CRP, but we're not really looking to bring down inflammation in general practice. We're not, or in primary care. If we find inflammation, we're not equipped with the tools to dig for the root cause of inflammation unless it's infection or a mechanical source. And then finally, something that's complete blind spot to traditional medicine is methylation. And so this is a new thing that's emerging. We've been testing it because for about 10 years, actually, when I started doing functional medicine, who I was trained by my mentor in America, we started delivering personalized medicine, looking at your breakdown of your cholesterol, so your lipoprotein A. Has everyone heard of that? Your LPA, Yep, and your ApoB, we've heard of that. So now we're talking in that language, and you get some few nods in the room. That's a very recent phenomenon in the last kind of 6 months, I would say, in the UK. But I'll come back to the cholesterol. And then the second is homocysteine. So people that know about methylation will know about the main reason why, when it comes to related to the cardiovascular disease progression, we want to know about methylation is because if it works well, your homocysteine stays low. If it doesn't work well, your homocysteine goes up. And homocysteine is a toxic protein that, if it accumulates, accelerates the progression of blood vessel disease, which manifests in vascular dementia, blood vessel blockages, major vessel blockages in the heart and the major organs first. Those are four main things that we should be looking at. The diagnostics, when we look at those markers, and you've had our foundational panel of tests, it looks at all of those markers.
Yeah.
120 blood biomarkers, 70 of which are traditional medicine. But when you go to your GP and you say you have a problem, your energy is down, or any of this, or you want to manage your cardiovascular risk, you get 4 markers for your cardiovascular risk. So they're just looking specifically. They're not looking at all of the contributing factors. And so we're missing so much. So we created this foundational panel. It works amazing with our patients, and it allows us to identify all of the important foundations that produce the direct risk factors and the indirect risk factors. Going back to the final point on cholesterol, measuring LPA is very important, because if I want to bring my LPA down, which 1 in 4 people's raised cholesterol is because of, on average, because of LPA. Statins don't work. In fact, there's been huge studies to show that for 1 in 4, it increases their cardiovascular risk.
Yeah.
If you give them a statin. By giving someone a statin, if their LDL is raised because of the subfraction being predominantly LPA, you're increasing their cardiovascular risk. Right?
And that's
It's
a
crazy.
huge amount.
25%
Yeah.
of people that are on statins. So it's significant.
Mm.
And then you've got the side effects of statins as well.
Mm.
I'm not downtrodden statins. They have a role. But if that's our only tool,
Yeah. Like GLP-1s,
right,
they've all got a place,
they've
right?
got a place. And there are other types of medications. You'll hear now of some called Repatha, or the PCSK9 inhibitors, which is targeting more the LPA. There are supplement versions of these drugs as well. So you can use red yeast rice as a supplement, which is a natural version of a statin, but it's not as powerful as a statin. So you can start to use these supplements at the right point at the right time. Instead of metformin, you can consider using berberine, which in some people is as equally as effective. And so there's a role for supplements, but in the right person at the right time, you can utilize them. So
On that, can you
yeah,
test for how well someone will react to berberine, for example, or is it trial and error?
it's trial. There's no way to kind of really know in advance if someone's going to respond. You would be considering things on their diet and their
Yeah.
lifestyle, and looking at their other markers. So, when we're using it in practice, our medical team, if someone's more medical, they'll be getting the drugs first and the supplement second.
Yeah.
But if there's a window of opportunity, then we're going to go supplement first before longer term prescription of medications whenever we can, and lifestyle alongside that always. So that's cardiovascular disease. Now, you asked me what are the treatments coming out. So I talked to you about the important data points.
Yeah.
Okay. And we have a panel here called the Cardiac Inflammation Test Kit, which is a home kit which measures homocysteine, your breakdown of your cholesterol, your LPA, and your ApoB, your fasting glucose in HbA1c, and your CRP. So the 4 important drivers in a finger prick test that you can do at home. So that's offered for everyone attending here as one of those test kits you can be using. That's why we developed that kit out, because it's so important for people to understand their, not just cardiovascular risk, their vascular dementia risk, their brain health risk as well. My favorite treatment that we've introduced to mitigate against cardiovascular disease progression, because guess what? We all get vascular disease. It's why our organs atrophy over time, right? What happens to our organs? They shrink. Liver, brain, kidneys. Why is that? It's because they're enriched by blood supply, arterial, then it goes into a capillary bed, very fine capillaries. So if we get blood vessel disease in the major vessels, is it happening in the smaller vessels, in the capillaries? You bet, yeah, of course. If you get blockages in the major ones, you can get cholesterol deposition and blockages in the smaller vessels, which is then causing tissue, peripheral outer tissue, to die. Okay, so blood supply, perfusion decreases to these organs over time. Is one of the main reasons why we introduced hyperbaric medicine many years back, because I wanted to keep my patients' organs perfused. What does that mean? Delivering nutrients from what we breathe and what we eat, if we've got an efficient digestive tract, and getting good nutrition in, delivering those nutrients to our cells, which are doing the work to keep us healthy and organs not atrophying. So one of my favorite technologies that we've introduced is something called reoxytherapy. Now, we use oxygen in many different ways here. We use oxygen at high concentration, at high pressure, hyperbaric oxygen therapy. We use oxygen as 3 particles of oxygen, ozone, that has a different mechanism of action. And we now started to introduce low concentrations of oxygens in cycles, intermittent, hypoxic, hyperoxic training. And there's some great studies, clinical studies, to show its effectiveness at improving the heart muscle function, your ability to deliver nutrients in your plumbing, your blood vessels. When your pump and your plumbing improves, the things that it's delivering the nutrients to benefit, the organs benefit. Big studies to show your VO2 max. You've heard of that?
Yep.
Everyone heard of your VO2 max? You know, Stephen Bartlett's making it popular now because he just done the VO2 max test with Peter Attia in America. And Peter Attia is a great doctor and longevity doctor that has been raising the importance of physical training. It started in cardiometabolic, actually. Now he talks a lot more about the VO2 max, physical strength exercise, and the importance of VO2 max. This treatment protocol, doing this IHHT over 2 weeks, delivers an improvement in your VO2 max that's equivalent to a decade of natural decline, because it naturally declines as we get older. So we can reverse a decade of decline by doing the 2-week protocol. Now, it doesn't last forever. It lasts for 6 months. You have to do it twice a year. So if I want to be cycling when I'm 80, I need a certain VO2 max score. If I want to be swimming when I'm 70 or 75, 80, I need a certain VO2 max score. What does that represent? Your VO2 max score represents the amount of energy you can produce to do the functions you want to do. How much oxygen I can take and how I can deliver that nutrients and utilize and create, in the presence of oxygen, aerobic respiration, energy that can be used for function at a cellular level. The better we can do that, the better we will function.
So it's preventative heart health care.
Right. And so, yes, and when you have heart disease, your VO2 max plummets, right? Because you can no longer deliver oxygen nutrients around the body as well. Your pump isn't as efficient. If we can improve the heart tissue, the muscle, and the plumbing, make it more elastic and delivering more nutrients, that's a great thing. And so the studies have shown it can be used in diseases after heart attacks to help rehabilitation of the tissue of the heart and expansion of the lungs, or it can be used preventatively all the way into performance. So people, for endurance events, we use it with our athletes, and we're lucky at HUM2N to also be serving athletes because in some ways they're really nice test subjects.
I've seen some of your boxers.
Yeah, boxers we work with, racing drivers, and other sports as well.
We were also teasing at the start that there's some really interesting cancer diagnostics available now, and that's affecting more and more of us and our loved ones.
Yeah.
What have you seen available?
We've been keeping a very close eye on an interest with cancer. We have now incorporated 2 oncologists in the team that do repurposed medications for cancer that sits alongside traditional allopathic medicine. We obviously wanted to approach cancer care very delicately and carefully. And so we have built our competence into that space over time. You're absolutely right. Cancer's on the rise. Is it a surprise?
No. Unfortunately.
No. Why isn't it a surprise to you?
Because we're getting sicker and our environment's getting less healthy.
Our environment's getting sicker, right? And absolutely, and that is meaning these biological organisms that we are so dependent on our environment that we're becoming sicker. And you're absolutely right. And there's a direct correlation between immune dysregulation and the rise of cancer, and immune dysregulation and the rise of autoimmune conditions. So we need to be restoring. We need to have a healthy immune system that is restored through deep sleep, through good nutrients supporting the production of healthy T cells, etc., and to be reducing the things that wake up and trigger our immune system. Toxins, leaky gut, inefficient barriers to our immune system, foods that have, etc., etc. So one of the tests that we offer is the TrueCheck cancer test. There was a test previously that we never went on to offer, but we looked at. It's called the Gallery and the Grail. Have people heard of that? That was at one point the most cutting edge test to detect the earliest biomarkers for cancer. This one actually looks at something called circulating tumor cells. So it looks at the earliest cells that can develop associated with up to 70 types of solid organ tumors that can develop. So pancreas, spleen, esophagus, etc., which make up more than 80% of all cancers. And it can detect these circulating tumor cells with great sensitivity and specificity. And so it takes about 4 weeks. It's a German company. They've gone worldwide with it. It's great to be able to give your patients that confidence. Otherwise, what we're doing is we're waiting for cancers to grow structurally, either screening with symptoms, okay, rectal bleeding or GI bleeding, which would happen quite late in certain types of cancers, and means that certain cancers are very late to present. By detecting things earlier, guess what? It makes it easier to manage, less likely of surgery, more likely to respond to things like chemo, radio. And then alongside that, we're also offering these integrative therapies that can work alongside allopathic medicine, allopathic being traditional medicine. We are very keen not to work against traditional medicine. We work alongside traditional medicine. And so things like hyperbaric medicine, mistletoe extract therapy, etc. Some wonderful, interesting ones. I can see.
Wow, what's
we'll
mistletoe therapy?
We'll have to do a separate...
A Christmas special.
Or a cancer special.
Yeah.
And so there are integrative therapies that can be used alongside, that you can actually personalize to the type of cancer. And so you can check for sensitivities to the cancer cell of these integrative therapies: IV curcumin, intravenous mistletoe extract, ECGC, resveratrol. It will tell you if they're sensitive to these things.
Amazing.
As well as tell you cisplatin or the types of chemo that it's sensitive to. So we're getting to that level of potential of personalization that hasn't been available in medicine up till now. The data is getting stronger, the testing is getting stronger, but what's lagging behind is the interpretation of that data. We're not teaching our doctors, we're not integrating into our health system to have enough experts look at that data and make sense of it. At the most simple form, you can go to your GP and tell him, "Doc, can you tell me about I've been measuring my glucose monitor and I've been looking at my sleep. Can you tell me what that means related to my health?" And you'll see them maybe break out in a little sweat. Because they've not been trained in it. They've not had the time and capacity to go and learn about it, unless they have in themselves, and then understand how it relates to health. Over time, we'll be training more doctors. That will be more widely available. But the point I'm making is the science has moved to a point where these things are available. This level of personalization is available, which means that you're able to now identify the process of aging, identify sooner the diseases that commonly kill us, and intervene sooner, and therefore improve the trajectory of someone's life. Yeah.
Amazing. Now, I think this is a really good time to bring on Simon. So Dr. E, it's actually his birthday today. He's 41. And his biological age, last time he checked, was 24. But that's nothing compared to Simon, who's recently had his 70th birthday. And
I had cake.
And he had cake. And his biological age is 38?
Yeah.
38. That's incredible.
My gift was Dr. E gave me a blood test on my 70th birthday from my biological age, which is, I thought, very good of him. And it just came through, and it's 38.
So,
whatever that means.
Simon, how long have you been a patient here, and what was your motivation for coming?
Since May of last year.
Mm-hmm.
I've always been interested in health, wellness, that sort of thing. And with all the new innovations that came through, I got confused.
Yeah.
Honestly.
There's so much out there.
Broccoli's good for you, eat that. And so I keep buying all these supplements and nailing them and going, well, I don't know what that means. So, and how do you test? How do you know? So really initially was to get direction. Yeah. So that was the motivation initially.
And what were the kind of key concerns that you brought up, or that your blood's brought up, and what have you been addressing?
Okay, so there's two sides to it. So general wellness is my key. I'm not trying to live forever. I'm not sure I even want to, but for the time that I do live, to live and feel healthy and well and be able to move, then that will be good. I don't have a 38 biology age because I'm lucky, because I'm not. So I've had heart intervention. I have a hiatus hernia. I have 2 metal hips, and I have very high cholesterol. So you haven't just luckily picked a bloke who happens to be 38 with that age. So listening to Dr. E now, the thing that resonates with me isn't the sort of the flashy, glitzy, hyperbaric chamber and these things. This lot here are a team, and there's method in their madness, and there's proper medical application. And I can give two examples. So I have a hiatus hernia, had very bad digestion. The doctor who was allocated to me, so the doctor I had said, oh, you go in there, they put a thing up down your throat and up your thing, and you've got hiatus hernia. I go, great, what does that mean? Well, it means you go on PPI. And I go, what's that? It basically get rid of the stomach acid. Great. Anyway, you do that and you still feel sick and you don't feel great and your digestion's not good. It's just not great. And so you think, oh, it's because I'm 70, I'm getting old. So from that, we've just worked out that, yes, I do have a hiatus hernia, but my symptoms have nothing to do with it.
Right.
And you don't need PPI. So they've given me mimosa. It's a herb.
Yeah.
And it's gone.
Wow.
So the stuff, and the PPI's gone.
Mm.
So, and actually a lot of the things that made me feel ill was a PPI because it dilutes your stomach acid, you don't digest properly, and things happen that aren't great. Then the other side is, oh, you've got high cholesterol, you should take statins. To which I said, well, no, I'm not going to, because I've read a little bit about it. And actually this morning, I just came back from having a calcium screen, because coming back to what these guys are saying, it's not just if you have a high cholesterol, therefore have a statin, which is all you get when you go to your GP. They're saying, well, you don't have the other indications of that, so probably the cholesterol's not doing any harm. What does bad cholesterol do? Well, it clogs your bits up. So you go and check your bits aren't clogged up, and that's a calcium screen. So I had one years ago because to be fair, my previous doctor was quite into this stuff, and he put me onto it. And so I've just had another one. So this is exactly what Dr. is saying. It's personalised, and I like that because there's not cures.
So what are the kind of flashier treatments have you been doing here?
Oh, I've done a lot.
Yeah,
Oh, yeah.
I know.
Yeah, I'm up for it all. A cryo chamber, which was cold.
Yes, I've done that
I
too.
think I nearly lost part of my left nipple doing it because I went for a bit of a world record with it because I'm a bit of an idiot like that. And that was great. But generally, the NAD treatments that I've had some exosomes, facials, that sort of stuff. My energy levels are a joke. They're through the roof. Since I've been here, I've always been pretty fit and done stuff. I'd work out probably 3 times a week quite hard. I can do it every day now. And I really am genuinely bursting with energy.
What do you think is what's helped you with your energy?
The best thing I can say is that if there's whole different things that you're doing, and it's hard to point from one thing to another. I mean, I wear this thing, which drives me a bit mad because I don't want to be ruled by it. But I've seen that my sleep is ridiculously better. I feel anecdotal, I know, but I feel like I've got more energy and I physically can do more things. I get numbers back. Apparently I'm 38 years old. Great, that sounds good. I have a VO2 max of a 36-year-old at 48. So you pick up those things, and I sort of don't believe in any of them, but I like them all.
Yeah.
And they must be doing something. I couldn't choose which one is doing or isn't, but it's working because I feel great.
Well, that's amazing, isn't it? So are you in it for the long haul now?
Yeah.
Because you're going to have to keep it up, aren't you?
Well, that's the thing.
Yeah.
So
It's a commitment.
I'm knackered now. I mean, because all of a sudden there I am, the poster boy. But if all of a sudden I go back and I'm up to 45, I'm going to go into a heap of depression. And I've got used to now feeling this well. And I mean, one of the other things I've done, which I've never thought I'd do, is I've stopped taking alcohol. I was born in a pub. Tricky. So I was brought up with alcohol. It was always there. It's what you did. I'm half Italian. You have wine with your food. You just do. But my mum, luckily, is not here. If she worked out I wasn't having wine with my food, I'd get a slap. You have a glass of wine, it's all right with your pasta. But there's evidence, and it's shown me that it's helped. So what ends up happening is 2 things, I think. One, you become mindful and you ask questions that people just don't ask, which goes against the tide, which is why there's a lot of resistance, because people don't do it. So what? You know, if it works, it works. But it's very hard to put your finger on, and you create that mindfulness, and then you become addicted to feeling well. So you're always going to chase and be after those things. I can't do that by myself. I need advice.
Yeah.
To get it.
Have you influenced other people in your immediate circles?
Yes, but most of them think I'm bonkers. They do, because it costs money and there's effort. I mean, you go down and have a NAD, it's 2.5 hours. It's dull. So you play Space Invaders or make some emails or do whatever. I don't live here. I come over once, twice a week. I have 3 days and I'm in and out of here. And it's pretty boring, but you know, if you get the result, you do it. So yeah, there is a commitment that comes with it. And I really thought, because for me, I think it's spectacular. I mean, it really is. If I'm 38, this thing says, what about if before that I was 44? So does that now mean that I've just bought 6 years of life? Who wouldn't want that? But people don't. And a lot of people glaze over, or I think I upset them. Maybe I pissed them off. I don't know.
We probably scare them a little bit because they're not doing that.
Yeah. So I sort of stopped a bit because I expected everybody to just go, oh my God, give me his number and can I do a deal? You know, but they don't. And I find that fascinating. So maybe I'm a bit weird like that. I've always been interested in this stuff. I've always practiced, I think, the best habits I could at the time, but I did it in an uneducated and an unsystematic way. All the stuff that I've had is not weird. It's not some funny chemical where you're going to grow a second ear or whatever. It's stuff that's in your body, but it's accurate, it's considered, and it's not quick, because you're having all this methylation stuff and these tests and these whole things, and they're studious and they're focused, and it's got rhyme and reason to it.
That's amazing. Thank you so much, Simon.
Pleasure.
Dr. I wanted to take it back to your view on general population. Unfortunately, you can't work with your patients in your East London GP clinic in the same way that you can work with Simon. But how are these worlds going to meld together, do you think? And what kind of practices can we take from these learnings and apply to our lives?
There's 2 questions there. Is like,
There's many.
Yeah, two questions. One question I took from that was, how do you scale personalized medicine? It will happen over time as more evidence is built in delivering this care, whether it's anecdotal through patients, whether it's through a body of clinical evidence that is growing. You know, we pay for healthcare. It does cost to deliver, but we just don't pay to receive it. And so countries like America, where insurance covers this type of care, eventually our insurance will start to cover this type of personalized practice, be it through the NHS or through private care, and hopefully you'll eventually get into the NHS. The second question is, how do we get doctors and healthcare providers doing this? And I think it's going to be through education. As we build systems to educate healthcare providers and build integrated care teams to deliver this. I see that happening through a postgraduate training program for doctors. I think GPs are really well positioned to do that. We recruit GPs that do functional medicine as a core training, and then we further training in this. And then the final question, which is, how do I apply this in general practice? I find it very difficult, actually.
Because you've got like 5 minutes with someone, right?
Yes, it's very difficult. In general practice, what are we doing? We're risk managing. I find that I can manage risk much more considered with more data when I've got more time with my patients and more tools at my disposal. I find that very difficult in general practice because I don't have the tools and I don't have the time. And so the risk management is harder. So I can't say, okay, let's try these lifestyle modifications immediately before doing that. Or even though we discuss that, we give them more options. Yes, there's more conversation, but even myself as a doctor, there's still less I can offer them. I can't talk to them about supplements. I don't, I can only talk to them about what's traditionally available in the NHS for them to trial medication wise and what's forthcoming, and then talk to them about what they could do in their nutrition, movement, sleep, stress, and help them understand and get the light bulbs going off on how the human body operates and think about it differently.
And then I was also thinking, Simon is your model patient. He's throwing the kitchen sink at this. I am always interested to know what is the least I can do for the maximum results. And I think that is also an area to explore.
Yeah, everyone is different, right? It depends. Everyone has a different propensity to age and a different propensity to get disease and a different requirement that they're putting their body through. You as a busy mum of 2, as a busy journalist working in industry that's quite a tough industry, have a lot of demands on yourself, right? So I think the first place to go to is understanding and working on things that will build up your energy. How can you replete your energy state? and how can you remove things and understand what depletes your energy, be it things that drive inflammation. So understanding what drives the inflammatory response within your biology for you, could be through certain foods. Doing something like a leaky gut test is really helpful. Then alongside that, things that replete you through micronutrients and macros, appropriate micronutrients, so B vitamins, C's, minerals, amino acids, and then also looking at how you deplete. And so what is depleting you?
It'd be the same for all of us, wouldn't it? But
Like
yeah.
stress,
Yeah.
inflammation, things that
Mm.
drive inflammation, toxicity through what we put into our bodies, toxic people that consume our brains, and then that causes us to take up a lot of energy and thought processes. Not sleeping, that is very restorative sleeping. And so those are just some insights. So developing that energy relationship with yourself, understanding where your energy state is at.
Mm.
Think of yourself as Duracell battery, and understand when you get into the reserve what goes off. Like you become less irritable, you might become more irritable, more restless, you can't concentrate as much. Those are your early warning signs. Your immune system depletes, you get a cold, it lasts a bit longer than it normally would, you're bloating and your digestion. So those are and then you start to seek to fix those early warning signs. You'll find that you deplete yourself less, and you're less likely to get into more accelerated disease, because rate of aging is related to your ability to recuperate, regenerate, and replete. If you're depleted, you will age at a more faster rate.
Mm.
Okay. When we're sick, we age faster. And that's why the decline towards death is always quite rapid towards the end.
So this is how everyone creates a blueprint for themselves, for their longevity blueprint.
Correct. Yes. Yeah. So think about, and we can go through different sections of like, sleep strategies as well. But you got to think of, things that you can do to preserve your deep sleep. So that's number one. You sleep for longevity. That's the most important type of sleep you want to be working on. In terms of nutrition, there's a few different strategies you can be using, but use food as fuel. Try not to eat too late. You can use intermittent fasting if you're not depleted, if it's not causing you a poor energy state. Intermittent fasting within nutrition. Movement strength is really important to maintain and prevent sarcopenia or muscle loss, but also your cardiorespiratory system. So you're doing low intensity steady state exercise, 45 minutes twice a week, mixed up with breaking a sweat. So high intensity training once or twice a week, and your strength. So that's your movement. And then things around stress, managing your state, your stress response on the outside, looking at your heart rate variability as a proxy for your physiological stress response, and then modifying your environment according to that. So those are some of the key things to do that will likelihood be delivering you and extending your state of health, your health span.
Amazing. And if anyone's writing articles about that, you can dive into each of those pillars in more depth.
Absolutely.
Now, I wanted to end on the very kind gift that you're giving everyone. There's a choice of 2 tests that they could take home. Would you like to quickly explain the difference between the two of them?
Absolutely. Yeah. So we're giving everyone one of 2 tests. Absolutely right. So one is the gut barrier panel test that looks at the integrity of the small intestinal wall. Now, this is really important because through which, if it's not healthy or if it's leaky, we will drive inflammation through that into our bloodstream. Is one of the drivers that we've seen of an inflammatory response. So in our approach, everyone gets that test as part of the functional medicine-based approach, our foundational panel that we do. But we've also got a direct home testing kit. So that looks at 4 markers: zonulin, occludin, which are proteins that get broken down in your small intestinal wall that's suggestive of leaky gut, which we can repair. We'll give you nutritional strategies and supplement strategies to repair. Candida, which is yeast overgrowth, which is quite common. We're seeing that in quite a lot of people now because of antibiotic exposure over time. And lipopolysaccharides, which is an endotoxin released by an overgrowth of bad bacteria. We've all heard of the microbiome. We now know that we're more bacteria than human cells. And guess what? Some of us have an overgrowth of big dysbiosis or bad bugs. And as Simon mentioned, Nevemosa was there to treat a parasite that we detected through a stool test that got rid of his symptoms that were otherwise thought to be a hiatus hernia. So the gut barrier panel test is a good insight for anyone that wants to optimize digestion, which is a very important step to deliver nutrients to all of our cells. The second test is for people that are interested in their long-term cardiovascular risk, which could be manifested in Alzheimer's disease risk or heart vessel risk. So if someone's got within their family heart disease or dementia that runs in the family, I think that's a good test to do. Those markers are also in our foundational panel of testing when people go on a health program, but we put that in the cardiac inflammation test kit that looks at 8 markers. We talked about them earlier, the 4 important systems that drive cardiovascular disease. So blood sugar response, homocysteine and methylation, lipoprotein A, ApoB, so we break down of your cholesterol so we can give you a real personalized plan. One of my favorite tests, and I think that's going to become more mainstream over the time. I still think we're not talking about leaky gut enough, even though we're talking about microbiome so much. Actually, it's more important to treat leaky gut than microbiome. And it's more actionable in practice that we're seeing. And the next thing that we're going to be talking about is modifying and personalizing cardiovascular disease risk, vessel health risk through deeper testing and understanding. The only reason why we're not testing it is because not enough doctors know about it and know how to use it. And then the final thing is the NAD. Who's heard of NAD plus? Yeah, wow. And pretty much everyone has, and it's phenomenal. That's taken off in the last year. We've treated thousands of patients with NAD, so we've got our own NAD plus home kit. So if anyone wants to try it that hasn't tried it and is interested to look at how that modifies and creates health through increasing cellular aerobic respiration. So it works in 3 ways: increases energy production at a cellular level, improves dopamine levels. We all want more dopamine, so that helps with our motivation, and then also works on longevity processes that happen behind the scenes that we don't notice. Those are the kind of DNA repair mechanisms activated by a family of proteins called sirtuins and PPARPs, things you don't really notice but is important behind the scenes activity. So we've got one of the 3, and then if you can come and see Ashley, Morale, or Beatrice, or Dr. Surya, and just let them know, and they will organize one of the kits for you to take away. Yeah.
Amazing. So have a think on that. Now, does anyone have any questions before we wrap up? I think we've talked a lot, but yes, please.
What is the pricing of, coming for a full test and then starting the whole process, like kind of a breakdown of that if it's
Absolutely, yeah. So the way we deliver this personalized medicine, we've been trying our very best to make it as affordable as possible, but to deliver outcomes as well. So we deliver it at £299 a month over a 12-month program of care. Very reasonable. And it includes a twice annual set of bloods, working with a postgraduate after GP specialist. They need to train further in functional medicine for a couple of years, and then they get in-house trained as well with us, that work with you throughout the year, and in functional nutritionist that works with you monthly. And that allows you to work through this personalized medicine way and start that journey. It doesn't include the further specialist epigenetic tests, which can get prescribed to you as required over and above, but 75% of patients don't need the further specialist testing. We wanted to make this as accessible and affordable as possible. It's available nationally, so people can work with us remotely from around the UK, and they can get their bloods drawn. We can send the kits out to them. In terms of outcome, in the last audit, we found that patients get a 42% improvement in self-reported outcome of health. We use a medical systems questionnaire as a validated scoring score that we use at the beginning. And then at week 12, in our last audit, we saw a 42% improvement in people's self-related MSQ score, which looks at their whole health, which is quite significant in 12 weeks. And that's through prescribed supplementation, nutrition, lifestyle strategies that we're delivering to them in an iterative way over the 12-month program of care. It's a new way of doing medicine. Yeah, it's not one prescription forever. It's a prescription for a couple of weeks. When we check in, we iterate it, we fix that one problem, we move on to the next. But we identify that through this deeper foundational panel of testing.
I was just wondering how you bridge the gap between what you're doing is kind of preventative and improving health, between the traditional health service, which is just, literally putting a plaster on his larger.
Yeah.
And obesity is a good example, because obesity is now is a disease, and people are rightly told not to think it's their fault. But with doing that and treating obesity with bariatrics and injections, you take away that responsibility, which you touched on. What do you think we can do to reach the mainstream, bridge that gap?
I think it comes through the healthcare providers, right? I think we have to empower our providers with systems, the way we deliver the medicine, to be able to support lifestyle behavior change. Empower the professionals to understand that, yes, it works, there's a strong body of evidence, but this is something a patient can do if they're supported to do it. And when the safety nets to use those medications. So the answer is, it requires systems change and support.
It's taken a long time on it, and
Not necessarily. It takes the intention and the will of the NHS, right? It didn't take me a long time.
No, it's good.
I wasn't funded by the NHS. I was, I was self-funded.
Yeah.
I went after something that I saw that I wanted to deliver this type of medicine, and I built a practice around it. So if I can do it, then I think our NHS can do it. And I'm very confident it can. It just needs will, and it needs an attitude shift from the highest level, which is saying that disease is not what we're going after. We need to redefine what health is. It's not an absence of disease. It's a state that we can engineer and improve people's health, whoever you are, whether you have a disease like cancer, or whether you want to prevent the diseases that you all get and die from inevitably.
And so I just want on the obesity thing, the future for obesity as it is like chronic in this country, well, everywhere really. But it's a pandemic, isn't it, in the UK? So how do you think you can shift the obesity prices? Do you think there is a shift now with peptides and the other interventions?
I think that the interventions are there now with peptide. I think that's going to be that is helping. Ultimately, it needs to change the way we live, right? We need to be less sedentary on our laptops. And so I don't know how the environment's going to shift over time, how humans will live in Western societies. But I think COVID's been cool because people are leaving the city and getting out into nature more, and work from homes more. We are seeing that change. The 90s and 2000s was all about going down to the pub after work, and now it's going down to a CrossFit or a Higher Rocks. So I think the younger population are really engaged with their own individual wellness and societal wellness. So I think there's definitely things to be positive for in the future of people taking autonomy over their own health. And I've seen that. I've seen the people that are into wellness rejecting the idea of doing peptides. And then there's another big body of people that aren't doing things themselves already that want the quick solution. So there seems to be a split between the way people approach their lives, really, just taking responsibility versus those that don't take responsibility. And I think that's the two poles we're dealing with. And I think the don't taking responsibility will always want medications and will be for the NHS. And the ones that want to take responsibility won't be able to get the answer from NHS. And they're going out and doing self-testing and they're doing the self-health things. And that's growing.
Yeah, thank you.
You're welcome.
Gentleman with glasses.
With regards to like delivering personalized like medicine per se on like a mass scale, how much of a impact do you think like AI will have on like being able to help with regards to that?
Yeah, I think it's definitely going to help. It depends what information is being fed into the AI, right? Like how is that algorithms being fed? And it needs data to be fed. I compare personalized medicine to different restaurants. People can have the same ingredients, but can get two very different experiences of their meal. And that's the same thing that's happening in medicine, but also personalized medicine. And so if that chef that's doing it in one restaurant is building the algorithm, which is what we're seeing, on this is what will generate help, this is the trigger points, and etc., it's going the output's going to be X. But another set of clinicians who see a different population will have a different algorithm of care. Okay, to go with gut first, then look at cardiometabolics, then look at their methylation, different process to deliver outcomes of health. I think there's going to be some short-term AI stories, sensationalism. I don't think it will deliver clinical outcome for a while. I think that will come in 10 years' time, but I think definitely in 10 years' time, we can expect to start to make sense of basically the computational biology that's required to make personalized strategies that iterate over time to address people's evolving health needs.
Last two questions there. Yeah. Sorry.
As you say, I think historically the longevity conversation seems to have skewed male. And I'd like to know about your clientele and the kind of gender split and whether you've observed that or you're getting more women through the door.
We're about 50-50. We're seeing an equal split, and interestingly across all ages as well. Yeah, 50. And I think the functional medicine that we do is, attracts more of the females, like solving problems with the disease-based conditions. But the people that are coming for us with, I want longevity, and using that word, they are more male.
And Lee at the front.
Yeah, we've spoken a lot about how, as a society, these physical chronic diseases like cancer and diabetes and obesity are increasing. But I was wondering if mental health conditions are something that you think about and treat in terms of longevity, because that's also increasing, especially in younger generations. And if there are any like emerging treatments to that as well.
Oh yeah, such a good question. So far in medicine, emotional health, I call it emotional health or mental health, is treated as in the mind, as if the mind is not part of your body. In traditional medicine, you can go to your doctor with mood disorders like anxiety, depression. In general practice, I see a surge in ADHD, self-reported ADHD. I'll come and explain that in a second and why I think that's happening. But we don't check the biology. We don't check your thyroid. We don't check your iron. We don't check your digestive tract. We don't look for the underlying biological processes that then produce your serotonin, process your tryptophan that converts it into serotonin for mood, or might deplete your dopamine that will cause you to be more likely to have the ADHD or substance misuse behavior. Biologically, you can look a bit deeper, and we do. So the methylation epigenetic test that we look at looks at how you recycle neurotransmitters from a genetic predisposition perspective. And that is a very powerful test that I'm seeing in clinical practice that helps me have conversations with patients. And wow, you don't recycle your noradrenaline and adrenaline as well as others. You're more likely to be restless. That makes sense because I'm feeling more restless. I get more anxiety propensity. Now, emotional disorders are always triggered usually by our environment. What's going on in our life? Usually there's always triggers apart from certain scenarios, right, which are more pathological, schizophrenia, etc. The mainstay of what's presenting in primary care and the bulk of it is situationally triggered, but also has a biological component to it as well. And there's conditioning, of course, over time. There's the psychological approach, which is conditioning over a period of time, childhood, etc. So there's absolutely the role of that. But I definitely think that we ignore the biological component. We're not trained to look deep enough in it. In this personalized medicine approach, we've definitely got more tools to help with it. Now, ADHD, I said I've mentioned some, and there is a massive epidemic of ADHDs that's self-reported in primary care. So much so that there's a 2 to 2.5 year waiting list just to get an assessment in the NHS. Of my GP clinics that I run in the NHS, I would say of a 30 patient list, 5 to 7 patients of all ages are calling up and saying, I definitely am restless, I'm distractible, I'm hyperactive, I want an assessment of ADHD. And then I'm going back to those patients, what's your screen time? Almost jolting them straight away to think, could this be me? Could I have a role in creating the way I'm thinking? And yes, we have, of course, the way we live affects the way our biology adapts, right? So if we put ourselves in cold exposure all the time, we make energy faster, and that's why cold exposure is better. We're drawn out metabolically more flexible. If we look at short attention span things and we consume that through our eyes all the time, we train our brain to be short attention span. And guess what? If we're short attention span, that makes us distractible. It's hard to stay focused, makes us a bit more restless, hyperactive. We can decondition people as well. And then there's a biological component of that as well, which is that person predisposed to it because they don't recycle neurotransmitters? Therefore, we have to get certain micronutrients in at higher concentrations in certain forms that can help them with their recycling of their neurotransmitters. That's what we're finding very helpful. Things like S-SAM-E as a supplement for those patients that have a methylation issue in recycling their neurotransmitters at the COMT gene, CRNT gene, which means that they get a block and they cannot recycle those stress-related neurotransmitters. And that's found in our methylation epigenetic test. And there's other supplements as well in there. So that's a one test that is I'm finding very useful. It's a methylation epigenetic test. We use the Life Code Lab. It's actually a British lab. They produce a great report. It's on our website. It's $5.95 for that test. But it gives me as a doctor more insights into mental health conditions, into hypertension, because it can help unravel someone's hypertension, into inflammatory conditions, autoimmune ones, because it shows us how we process our antioxidants, and then also cardiovascular disease, because it shows how and whether we manage our homocysteine well or not. Now I've got more information to look for the etiology, we call it, or the process of developing those diseases that otherwise is limited. Hypertension is limited etiology. Oh, it's a condition. Maybe is your salt too high? Is your diet pretty bad? Genetics? Don't know, maybe. There you go. Right? There's a drug. And 1 turns into 2, 2 turns into 5, 5 turns into 15. Right? That's inevitable. When you're medicalized, it's inevitable that your medication goes up. In this approach, you start high on supplements or naturally occurring ingredients, but they actually go down over time. Your quite goes down. I went off on tangent there, but I think hopefully that definitely answers the emotional health approach in personalized medicine.
I'm going to draw this to a close now. I'm sure there'll be more questions flinging around your brains, and you can
Yeah, I'm here to
get in touch later or Instagram or something. But anyway, thank you so much for your time, Dr. E. That's been fascinating.
Thank you very much.